Hello. So I'm going to be doing an airway assessment on Bob here, since he's the most willing participant I could find. An airway assessment consists of a variety of factors, one of them being a Mullen-Potty classification or score. Basically tells us how much space we have in the mouth to allow for ease of when we use like direct laryngoscopy or when we intubate. So the best way to measure is when a patient's in a neutral position, kind of facing you, kind of like this, and they open their mouth, stick out their tongue, and without any phonation, so without saying like ah or anything, we look inside the mouth and we see what we can see. I'll try and post pictures of different scores that we give people. It's from 1 to 4. 1 is basically when we see the soft palate, uvula, fauces, and tonsillar pillars. Classification of 2 is when we see the soft palate, uvula, and the fauces. A 3 means we see the soft palate and the base of the uvula. And a number 4 is bad, very bad. We don't even see the soft palate. So that is one way to tell. We also want to check the thyromental distance. That's basically the distance from the chin. I should probably go on the side. Basically from the chin to the thyroid cartilage. So thyromental distance. Thyroid to the chin, which is mental. And we want it to be like 3 finger breadths, which is about like 6 to 7 centimeters. So we measured that. We want to check for the degree of the mouth opening, how wide they can open their mouth, assess the range of motion of the neck. Can they can they flex really well or can they extend really well? Check the neck circumference, and then also look at the teeth, look at the size of the incisors, and also see if they have any like artificial and removable structures like dentures. So there are non-reassuring findings, and I'll tell you what the bad findings are. If you have relatively long upper incisors like buck teeth, that can be really bad. If you have a prominent overbite, if you have an inability to bring the mandibular incisors anterior to the maxillary incisors, so if you can't bring your bottom teeth over the top teeth. If the incisor distance, which is basically the space in between the bottom and the top teeth, we usually want it like 2 finger breadths. I don't recommend you putting the fingers in the mouth, but if you can kind of assess it next to it. But this is a mannequin, so I'm just going to put it in. So if you want it, about 2 finger breadths. If it's less than this, then that's bad. It's about 3 to 4 centimeters. So less than that, less than 3 or 4 centimeters is bad. If the uvula is not visible when we do the Mullen-Potty score, which is basically grade 3 and 4, that's kind of a bad finding. If you have a highly arched and narrow or very narrow palate, if you're kind of like a like stiff neck, or if you have a mass, or it's a non-resilient neck, that can be bad. If it's a short neck or a thick neck, that's also bad. And if you cannot flex your neck to touch your chin to your chest or extend the neck really far, and those are also really bad findings of the airway assessment. Thanks, Bob. When talking about basic airway management, it's important for us to know what the anatomy is. So there are 3 important structures among many that you should know. Obviously, this is a mouth. As you can see down here, this is the thyroid cartilage, the cricoid cartilage, and then in between there's a space right here. That's the cricothyroid membrane. There are other structures that you should know, but I think for now, those are the important ones that you should be familiar with. I want to talk a little bit about positioning. It's important that the patient is positioned appropriately. That way you don't hurt your back when you're leaning too forward and the patient's too short, or if the patient's too tall on the table, then you can't really maneuver really well when you intubate. So it's important that the mouth is kind of to your xiphoid process. So right now the patient's too low, so I'm just going to move him up. Yep. Okay, we're good. You also want the patient in a sniffing position. Basically, it's when the external auditory meatus is to the level of the sternum. You can do that by placing a pillow underneath the patient's neck. If the patient's obese, you can also do something called ramping, which is when you place a bunch of pillows behind the back, shoulders, and the head to make sure that the axes are aligned. It just allows for easier view when you are getting ready to intubate. The arms of the patient should be supported or at least on arm boards like this, so that's perfect. And then for me as an anesthetist, I want to be at the head of the bed facing the patient. You also want your left hand to be on the mask and your right hand will be on the bag. This is kind of the standard position that you'll be in for the case. So that's it. When masking a patient, you want to make sure you place the face mask appropriately. The top part should be aligned with the pupils. The side should be by the nasolabial folds, and the bottom part of the mask should be between the lower lip and the chin. So they use a technique called the EC clamp. Basically, you make a C. So the C part is your thumb and your index finger, and the E part is the last 3 fingers. You want to put your thumb on the top part of the mask and your index finger on the bottom to do counter pressure to keep the mask on the patient's face. With these 3 fingers, you put it on basically underneath the chin along the mandible, only on the bony side, because if you do the soft tissue, that can be tissue damage for the patient, which is not cool. So once you have that kind of in this position, you do basically like a head lift jaw thrust type of a move where the head can kind of go back like this. Then there's also if you kind of push too hard during the face mask, part of the facial nerve can be damaged. The buccal branch of the facial nerve can be damaged. There are these things called face straps that it's kind of nice. It frees up your hand so that if you're the only one, basically you have no assistance in the OR, for example, this can secure the face mask while you get ready to get your airway equipment or get your drugs ready. The facial nerve branch that can be damaged with this is the zygomatic branch and the mandibular branch too. So you gotta watch out for that. Don't put it too hard against the patient. And then of course, if you have appropriate seal, you can assess if you're masking well by checking for like chest rise, hearing if there's a leak, and if there's a leak, the C part of the EC clamp position, you should always go towards where the leak is. So if, for example, there's a leak that I hear and it's on the right side of the mask, I want to lean it towards the right side and then be able to then mask the patient. And that's how you properly mask somebody. I'm going to be talking a little bit about oropharyngeal airways, or oral airways as they are called. They're usually used for upper airway obstruction, absent airway reflexes, like when the patient's unconscious, or as a bite block, especially if they're biting down on their like ET tube. So you can see there are 3 different sizes. This is an 8, a 9, and a 10. And they're also color coded, so you can see green, yellow, red. I like it because it's like a stoplight. Green is go, yellow is slow down, and red is stop. So it's an easy way to memorize the colors with the sizes. I think the average size is usually the 9 in the middle. When placing these, some of the complications that can happen is a glossopharyngeal nerve injury, because if you realize, if you think about the anatomy, when you place oral airway in the mouth, there's the oropharyngeal nerve is actually right in the path of where you'd be placing the oral airway, so there could be injury to that, as well as venous and lymphatic obstruction. So I'm going to show you the best way to kind of measure how to, or measure what, figure out what size by measuring it on the mouth and the mandible. What's best is if you look, this is kind of, it's called the phalange, or the, you want this at the outer border of the mouth, kind of like measure it like here, and then you want the tip to be kind of to the angle of the mandible but not past it. So the angle will be like around here, and as you can see, this is a little, it's kind of short. I'll try the red one. Maybe I'll overcompensate for it. It's actually past the angle, so this might be a little bit too big. So I try this one. It seems to work pretty good. So I'm going to go with a 9, which is pretty average. So to insert one of these in, you can use a tongue blade. Usually the tongue is a big obstruction in a lot of the airway management that we do. So you can use the tongue blade to move the tongue out of the way, or you can do something called a scissoring technique, which essentially you make like an Asian heart symbol, and you increase it though. So you can scissor like this by allowing for more space for the oral airway to go in. So when we put it in, you want to essentially like kind of insert it on the side and then gradually shift it into the right position, and it should just fit like this. The flange should be resting against the lips, and the tongue would normally be kept in the forward position. Thankfully with a mannequin it is, but this is when a tongue blade would be helpful. And you want to be able to avoid the soft tissue and dental pressure or injury when you place this in. But now the patient has a better way to breathe. There you go. Next, I want to talk about nasopharyngeal airways or nasal airways. Kind of look like this. Some indications for use is that if there's an upper airway obstruction and the patient's either unconscious, semi-conscious, or awake, you could use this. There are some potential complications and contraindications of this use. If there's bleeding or coagulopathies, a basilar skull fracture, or facial trauma, it's probably not good to use this. So the best way to put this in a patient, you want to measure it first. So this is the flange, this part. You want to basically put it on the outer border of the nair, and then it should, the tip, this part, should reach but not exceed the external auditory meatus. So as you can see, I am definitely going past that. So I would try maybe a smaller one. We'll see. The nair going to, oh, this is like perfect. Okay, cool. So before you put it into the patient's nair, you make sure it's well lubricated so that it kind of goes in smoothly. You want to insert it at a 90 degree angle, perpendicular to the patient. And then once you put it in, essentially this flange part should rest against the nair. That's how you put it in. This is an example of an LMA, or laryngeal mask airway. Some indications for its use include procedures that last less than 2 hours, or the patient pathology or procedure does not require a secure airway. There are some contraindications for its use, however. If you've been NPO less than 6 to 8 hours, if you're morbidly obese, greater than 14 weeks pregnant, if you have multiple or massive injuries, if you have an acute abdomen, not an ugly one, but an acute one, thoracic injury, delayed gastric emptying, opiate usage prior to fasting, trauma, if your peak airway pressure is greater than 20 centimeters of water, and if the patient is unable to answer or understand questions about medical history. Those are just some of the contraindications of using LMA. When determining the appropriate size for the patient, you can look at the size of the posterior pharynx of the patient, or base it off of weight. And I'll show you a table that we use to figure out what size LMA to use. So when you prepare it, you want to be able to apply lubricant to the anterior side of the device, so it's this side. As you can imagine, this is the side that's going to be sliding in to the patient's mouth and then sitting comfortably on the posterior pharynx. Another view of when you insert this is basically when you're going down past the tongue, you kind of essentially put it in here, and it should sit comfortably inside. You inflate the cuff, and then once it sits there, as you can imagine, the air will be going through the tube. It's going to be pushing it out, and the vocal cords are right there. So that's essentially how an LMA works, and if you put it correctly, it should, you know, be like that. Once you correctly place the LMA in, you can insert the air to adequate seal, and you have to be able to assess if there is proper ventilation and if you have to add more air in order to seal it. So you do that with checking for chest rise. When you do manual positive pressure ventilation, you see if there's adequate tidal volume for a patient weight with positive pressure ventilation less than 15 to 20 centimeters of water. And then another way is to see if there's a minimal leak with airway pressure less than 15 to 20 centimeters of water. You can assess that by auscultating over the trachea over here. So those are the ways in which you put in an LMA. Endotracheal intubation, what most people enjoy about anesthesia. So I'm just going to kind of talk about boring stuff like the indications that someone would need an ET tube placed. If the patient has an inability to protect the airway, there's an impaired respiratory function, or if you want to prevent high CO2 or hypercarbia, those are some of the patient conditions that would kind of indicate for an ET tube. Surgical and anesthetic indications include like a requirement for neuromuscular blockade. Since you're paralyzing them, they can't breathe. If the airway access is shared with the surgeon, with some like ENT surgeries, the patient's position restricts access to the airway or precludes rapid tracheal intubation. If you predict that there will be a difficult airway and there's a risk of aspiration of gastric contents or blood from any cause, if it's a surgery that impairs gas exchange, if it's a prolonged surgery, and if there are other airway techniques that are ineffective. There are certain ways to determine the size of the ET tube that you'll be using on the patient, like gender, weight, pathology, and the surgical procedure. And I'll tell you right now, the range for a woman is about 6.5 to 7.5 size, with the average being 7.5. And for males, it ranges from 7.5 to 9, with an average size being 8. So here I have a size 8 and a size 7. I'll tell you right now, one way to tell is you can look at the bolded number right here. That tells you the size of the ET tube, 7 and 8. It also can tell you up here towards the tip, if you want a quick and easy way to tell what size you're using. So basically, anatomy of ET tube. There's a cap here. This is what attaches to the ambu bag or to the vent. After you intubate, this is a cuff. You can put air in it, and it basically will inflate this. It allows for basically to secure the airway and to help with anything going down the airway into the lungs, like secretions and stuff that can help block that. There's also something called the Murphy's eye, which is basically this hole on the side. If something were to obstruct this end of the ET tube, it's nice to have kind of a backup hole, I guess, and that's called the Murphy's eye. So I'll try and show you right here, but once you inflate, one thing you should do before you insert the ET tube is to check and see if the cuff has a leak. So you do that by inflating air, and then as you can see, it looks good. There you go. And then also there's something called a stylet. This is very flexible, which is good, but sometimes we need it a little bit firmer for when we insert it. And if you place this inside the ET tube, it actually allows for an easier way to insert the ET tube without it being too flexible. It's important that when you do insert this, to not let this poke out, go past the end of the ET tube, or poke out of the Murphy's eye, because then you can puncture the trachea, and that can be really bad for the patient, unnecessary injury. So I'll show you in a bit how best to position it. But this is kind of an introduction to ET tubes right now. So I just inserted the stylet into the size 7 ET tube. As you can see, it does not extend past the end of the ET tube or the Murphy's eye. I forgot to mention that when placing it, it basically should look like a hockey stick. It should kind of go straight. Then at the end, you can manipulate the stylet to curve it more if you want, or less. But that allows for easier passage into the trachea, and hopefully helps to point it upward when you're intubating instead of going down into the esophagus. So those are some of the parts of which you would check an ET tube, and also just the parts of the ET tube itself. I'm just going to talk about the different types of blades that we use in anesthesia. There are Miller blades, which are here on the right, and then Macintosh blades, or Mac blades, on the left. A typical average size for a Miller blade is a 2, which is this one. and this is a size 3. And a typical average size for a Mac is a 3, which is this one, and this is a size 4. Basically, the criteria for selecting which blade and which size kind of depends on the person intubating or patient indications. There are advantages and disadvantages for both types of blades, so I'm going to kind of briefly talk about it. So with the Miller blade, advantages is that you have more control of the tongue and there's direct elevation of the epiglottis. A disadvantage is that, as you can see here, there's a smaller point of contact with the epiglottis, so there's higher risk of trauma to the epiglottis and unstable elevation. Also, the cross-section of the blade may obstruct the passage of the ET tube. For a Macintosh, advantage is that the tip is atraumatic, and it indirectly elevates the epiglottis by putting tension on the hypoepiglottic ligament, so that is less of a risk to damaging the epiglottis. You can still damage it, but it's less of a risk. A disadvantage is that the web and the flange part are bulky compared to the Miller blade. Hi. So before we take the patient back to the OR, we want to make sure we set up the OR room. And the teachers taught us an acronym called MISMATE, so I'm just going to talk you through that. The first M stands for machine check. I don't know how to do that yet, but when I learn how to do a machine check, I'll make a video. So basically turn it on, it does a self-check. You want to make sure it's working, it's functioning well so that there won't be a problem when the patient comes in here. S stands for suction. Always want to make sure that's on. No suction, no induction is a rhyme that one of the teachers said. We have, suction tube in here. Usually you just kink it and put it in a spot. Always know where your suction is. That's really important for the preparation in the room. Next, M is monitors. You want to make sure like EKG leads are present, blood pressure cuff, SpO2, etc. A stands for airway. So you want to always make sure you have ambu bag. Have like oral airway, nasal airway, some tape, tongue blade. Make sure if you're anticipating like that the patient could be intubated, then you would have like some blades, Miller or Mac, some handles. There could also be an LMA, which I don't have here. Also ET tubes of different sizes. And if in case something goes wrong, you always want to have a backup plan. So have like a gyroscope or a fiber optic or other equipment that you can have as a backup plan. I stands for IV. Normally the patient will come in with an IV, but just in case something were to happen, like it were to get infiltrated or you need, it gets yanked out, you just want to have like a quick IV start kit set up in like a basin like this nearby. D stands for drugs. So you want to have like emergency drugs over here on the left. I'll talk about that later. And then there'll be drugs that you use for induction over on the right. And again, I will talk about that later. The last S stands for special equipment. If you might be placing an A line in the patient or like an OG tube, NG tube, that can also be some equipment that you have nearby. That's what you do to prepare the room before the patient comes in. Okay, so I'm just going to kind of talk a little bit about the drugs that we use in the OR. Specifically emergency drugs, which would be usually on the left side of the cart, and then induction drugs, which would be on the right. So usually for emergency, what we were taught is that we have succinylcholine. Concentration is normally 20 milligrams a mil, and Sux is a depolarizing muscle relaxant. Then we have basically a bunch of pressors, things that we can use for increasing the blood pressure, because usually one of the things we see is hypotension, especially with some of the drugs we give. The patient can have low blood pressure. So phenylephrine is something that's usually used. We want a concentration 100 mics a ml. It usually comes in a 10 milligram an ml vial, and in order to dilute it, in order to have the concentration we need, we usually have to put the 10 milligrams in a 100 milliliter like bag of NS, and then if you take 1 mil from that bag, it will equal 100 mics. So that's one way you can dilute that. We have epinephrine, which a lot of people know. We want the concentration to be 10 mics an ml. We also have ephedrine. Again, concentration is 5 milligrams in ml. So that's in its own class there. Then we have some anticholinergics. You have atropine, which we want a concentration to be 0.4 milligrams in ml. And we also have glycopyrrolate. Concentration is 0.2 milligrams in ml. I think most people either do one or the other, but for the case of this video, I want to talk about both. So those are some of the emergency drugs that we want to have on board. Typically on the right side will be induction drugs. There's midazolam. It comes in a 1 milligram to 1 ml concentration. You don't have to give this to everyone, but if the patient is exhibiting anxiety, this is really good to ease that. Then we have fentanyl. Everyone knows that helps with pain. Because the surgery and the intubation and the things that they'll be going through during the procedures will be painful, it's always good to give the patient some pain meds at the beginning. So fentanyl comes in a 50 mics per ml concentration. Then we have lidocaine 2%, which is 20 milligrams in ml. Just FYI in the future, if you see a 2% or a 1%, one easy way to convert that to milligrams is if it's a 2%, let's say it's the decimals behind the 2, right? So you move it 1 over to the right, so then it'll be 20, and that would be the milligrams in ml concentration. So if it's a 20% lidocaine, move the decimal point over 1, that would be essentially 200 milligrams in 1 ml. So that's the easy way to do math. But anyhow, lidocaine is given. It helps. It's a local anesthetic, but when you give it, it also helps to numb the area, especially because propofol, which we will be giving next, can be painful when you inject it in an IV. So lidocaine can help with that. Propofol is a common sedative that we'll use. It's very short acting, quick onset, and we like to use it often, especially for MAC cases or short procedures. So propofol usually comes in 10 milligrams in ml. And then we have, I talked about succinylcholine earlier. We'll usually use that for induction, but if not, we also have rocuronium. It's a non-depolarizing muscle relaxant and comes in a concentration of 10 milligrams in ml. This one takes a little bit longer to work than Sux, but it also has a longer duration of action, which can be good for longer cases. So these are essentially the drugs that we use when we're setting up the OR or just during the case. So thank you. So I want to talk about how to insert do like a direct laryngoscopy. And this is a handle, this is a blade. The first thing you do before you even attempt is to insert it and check to make sure the light's working. You can see, you don't want the light to kind of fail when you're in the middle of intubating. That would be really bad. So you want to have this laryngoscope in your left hand. When you get ready to intubate, you want to place it, make sure the neck's in the right position. You can do gentle extension of the neck, or just kind of do a scissoring technique, which is basically the Asian heart, and you extend it more in the mouth. It just opens up the mouth more, so you can fit the blade in. So you want to go in from the right side of the mouth, and basically your goal is to displace the tongue over to the left, so it's out of the way, because the tongue is a really big obstructive force when you're trying to intubate. In the mannequin, the tongue does not move, so just pretend with me. But you go in from the right, and you want to simultaneously move the laryngoscope to the midline as you displace the tongue to the left. So once you do that, you want to make sure to verbalize what you see. I see a hard palate, soft palate, uvula. I see the epiglottis. Once you see the epiglottis, make sure, depending on the blade you're using, I'm using a MAC blade right now, you insert it in the right place. So the MAC would be in the valleculae and the Miller would be under the epiglottis. When you are in the correct position and you want to keep your wrists in a neutral position and kind of do like an upward forward movement, so kind of aim for like the upper corner in the opposite of the room, like this angle. If you rock back and do kind of the flexion, extension of your wrist, it actually can damage the not the mannequin's teeth, but the patient's teeth. That's really bad. Dental damage can be one of the problems of intubation. So when you're in the correct place, you want to go up, kind of like up and forward. And then when you see the vocal cords, then that's when we get ready to intubate. There are external measures you can use to help when you intubate someone for a better view of the vocal cords. What you can do with your right hand is you can either kind of help extend the neck even more, you know, kind of place it right here, or you can put cricoid pressure, push down, and that helps to bring this kind of into a better view when you're doing direct laryngoscopy. Once you have an adequate view of the vocal cords, you want to ask your assistant to hand you the ET tube and keep your eye on the prize, because you never know when the view of the vocal cords can be obstructed later. When handed the ET tube, you want to kind of hold it like a pencil like this, about 2/3 distal to the end. So it'll be essentially like this. When you insert it, you want the hockey stick portion to kind of be like at the 3 o'clock position. And as you go in, you rotate it like this. When you go in and you kind of want to put the ET tube about 2 centimeters distal to the vocal cords. At that point, you can remove the stylet, advance it more, inflate the cuff to minimal occlusive pressure, and then you want to give a positive pressure breath and make sure it's in the right place. Maximum occlusive pressure is 25 to 30 centimeters of water. And then there's an acronym called SMELLS that we use to identify if we're in the right place and if proper intubation has occurred. I'll talk about that in a bit. Well, let's say you have a good depth, you felt really good about your intubation, and then when you check for breath sounds, you see that you actually inflated the stomach instead of the lungs, which can happen. It's an unintentional esophageal intubation. People call it's when you tube the goose. So signs, it's really important that you be able to identify the signs of an unintentional esophageal intubation. There's no chest rise. There's a lack of end-tidal CO2 waveform on the monitor. You don't have bilateral breath sounds. And if you auscultate epigastric sounds over the stomach. So you definitely want to remove and discard the ET tube, and then make sure you establish adequate bag mask ventilation. And you can use adjuncts for effective bag mask ventilation if you used it prior to attempting to intubate the patient, like an oral airway or something. So this is another thing that can happen when you think you intubated, but you actually intubated into the esophagus. So let's say you intubated the patient, you got overzealous, and you put the ET tube pretty deep. There are ways to identify endobronchial intubation, which is basically what this would be. This usually happens if you put the ET tube too deep. So let's say when you inflate and check, you have unequal breath sounds. So you can see the right lung. Sorry about the chicken noise. The right lung is inflated and the left one is not. It's easier with our anatomy to do a right main stem intubation just because it's more straight versus the left lung intubation. So you want to identify the depth of the ET tube, evaluate peak airway pressure. If you are a little bit too deep, you want to deflate the cuff, adjust the ET tube to appropriate depth, then reinflate the cuff with minimal occlusive pressure, so 25 to 30 centimeters of water, and then verify bilateral breath sounds and continuous EtCO2 waveform. So this is one of the mistakes that can happen when you intubate a patient. You can fix it, but it's really important that you identify, especially with uneven breath sounds and just looking at the depth and the peak airway pressure. To secure the ET tube, you want to make sure it's on the appropriate side, possibly the non-surgical side if possible. And the ET tube will be secured between the molars and the lateral aspect of the tongue, so it'll be the paraglossal groove kind of around here. Make sure the soft tissues are free of pressure, and you want to make sure to tape it securely. Now I'll have a picture of what that looks like. I'm just going to intubate Fred here real quick. I'll talk to you guys about how to assess for proper intubation. You see the vocal cords.
I'm gonna go in, move this eyelid out a little bit, advance it a little bit more. Inflate the cuff. Okay, so smells. Basically, the first S stands for see chest rise. So as you inflate, you would see the chest rise. M stands for mist. When the patient exhales, there'll be mist kind of in the ET tube. E stands for end tidal CO2. So on the monitor, you'll be able to see waveform and appropriate numbers. L stands for listen to lungs. So you want to listen to the left side. Want to make sure you don't do an endobronchial intubation where it's just the right side intubation. So as you can see, it's a very clear view that it's bilateral breath sounds. And then the last S is O2 saturation. So again, you want that to be an appropriate number as well on the monitor. That's how you tell if you intubated someone appropriately.